Well, good morning, everyone. Good afternoon and good day. My name is Greg McFall, and I lead the DeLorean Artificial Intelligence Global Renal AI Business Development Initiatives. Thank you for joining us in the session AI for Renal Care. Let me just start with a brief background on DeLorean AI. DeLorean AI is led by our founder, Dr. Sevens McLaughlin, who brings a wealth of healthcare experience and AI expertise. We, as an organization, are dedicated to driving AI, or innovative AI solutions in the healthcare industry. A brief background of DeLorean AI is we've spent nearly last 6 years dedicating our first 4.5 years in product development and our R&D, focusing on our flagship product called Medical AI. This advanced AI system addresses 4 chronic conditions: cardiovascular, diabetes, mental health, and renal. Renal AI is a significant portion and part of our Medical AI, which focuses on chronic kidney, CKD, and ESRD analysis. Early in our journey, we had the opportunity to collaborate with one of the largest health plans and multiple other health plans and data sets, encompassing a staggering 52 million members and over 1 billion claims. This extensive data set covers approximately 38 and 50% respectively of ESRD and CKD population, and has been pivotal in training our AI programs and ensuring accuracy and reliability. This substantial effort and investment in R&D and product development has contributed to our high accuracy rates in predicting mistreatments, hospitalizations, health transitions with next best actions. Today, our Renal AI will be showcased with our partner, Innovative Renal Care, IRC, and their AI solution, Innovative AI. Our co-host, Sarah Bradley, Chief Nursing Officer at IRC, and Dr. Kazim Butt, Chief Nephrology Officer at DeLorean AI, will illustrate how Innovative AI, powered by Renal AI, is integrated into the IRC facilities nationwide. IRC's Innovative AI revolutionizes the operations of care staff and executive teams while truly inspiring a new era of healthcare that improves outcome and patient health. Jointly, we recently released a white paper entitled Transferring Renal AI Care with Innovative AI. It focuses on IRC and DeLorean's it can be found on our respective websites. Now, let me introduce you both Sarah and Dr. Butt for this Renal AI healthcare session. Dr. Butt, he is a certified interventional nephrologist with over 14 years of experience. Today, he continually practices medicines part-time in clinics and in patients with telehealth. He is actively involved with healthcare innovation. Many of you may already know Dr. Butt from his LinkedIn Your Kidneys, Your Health podcast, which really focuses on renal healthcare and innovation. Sarah Bradley, Chief Nursing Officer, is Chief of Nursing at Innovative Renal Care, is one of our co-hosts. She is a Chief Nursing Officer with Advanced Masters in Leadership in Nursing Executive with Advanced Board Certification. IRC, Sarah, and her team focuses on caring for teams, supporting healthcare clinic excellence to improve kidney care. This combined leadership and experience fits nicely into our conversation today on how to operationalize AI in workflow, facility settings, and then day-to-day life. Now, please welcome DeLorean's Chief Nephrology Officer, Dr. Butt, and IRC's Chief of Nursing, Sarah Brady. Take it away, folks.
How y'all doing? Nice to be here with you, Sarah.
Yeah, it's a pleasure. Thank you. I was wondering if I got remarried with the Bradley comment, but
No.
you corrected yourself. It's beautiful, but I'm very, very excited to be here. This is a great time to be in healthcare. So thank you for that introduction, Greg.
Of course.
Thanks, man. So yeah, just to briefly introduce myself again, I've been a nephrologist, interventional and clinical for over 14 years. I'm DeLorean's chief nephrologist, but I also practice medicine part-time. So I'm still in the field like many of you are. So I know the problems of the day-to-day nephrologist and nephrology nurse and administrator that when you go to these units. So our goal at DeLorean and one of our and with the IRC is to deliver a product that is actually useful clinically relevant for people in the field. And that's what's been great to work with IRC with. They really are innovative. It's not just in their name, it's literally what they do. So it's been great to work alongside them and deliver metrics that matter. Right off the bat, like you can see our dashboard here. So this is one of the dashboards you can see. We concentrate on things and we give you predictions on aspects of care that you care about. Number of hospitalizations, numbers of mistreatments, dryway predictions, clearance issues, and anemia predictions as well. On this left-hand side, when you look at our dashboard, you can see a list of high-risk patients from red to yellow down. So you can really hone in on who's at risk for your patient, at risk for your unit, for your dialysis unit, or your organization as a whole. Up top, you'll see region name, clinic name, shift, physician. So it gives you the ability to splice and get down to the nitty-gritty of where the problem is. Is it a Monday, Wednesday, Friday problem? Is it a physician problem? Is it a clinic problem? Right? Where are you having those issues? Next slide, if you can, Carolina, that'd be great. So, I know that clinic manager, right? Or the facility administrator, whoever it is, that is a busy woman typically, right? Very busy woman. She's got to manage like 30, 40, 50 patients a day. She's got to manage the shifts of nurses, of techs and dialysis patients as well. So she's busy. So you don't want to overwhelm that person with a lot of too much information, right? So with our board, what you'll see is a list of patients. This is your top 5 of patients that you need to worry about, right? It doesn't have to be top 5. It could be top 6, top 7, whatever the algorithm predicts, but it'll give you a list of 5, 6, 7 patients that you need to worry about at your clinic and gives you the ability to concentrate on those. So that clinic manager, instead of worrying about all 50 of her patients, can go, I can hone in on these 5 and go, hey, let me do a little extra TLC on them. Maybe maybe talk to them a little bit. Maybe send the social worker out. Make sure that that person is doing okay. Well, and so for this particular list, it's the hospital admission list, right? The people that are at risk for hospitalizations due to fluid overload. Next line. And Sarah, feel free to comment on anything I say, by the way, just let me know. Okay.
You're doing great.
Oh, I appreciate it. So one of those people on that list was Mrs. Kaylin Peters. And now for the sake of argument, say Mrs. Kaylin Peters is the typical 65-year-old lady on dialysis. She's a sweetheart, right? Always shows up for her sessions, but you notice over the last few weeks that she's not acting the same. And her husband comes up to you and says she's tired all the time, right? Not doing well. Well, our algorithm here, our AI predicts, if you could go right up to the top, that she's at high risk for hospital admission for fluid overload, right? And you're like, okay, why? Why is that? Well, not only are we giving you a prediction model, right, or prediction of a hospitalization, we're giving you here the ability to do deep dive on a patient that ordinarily you would never be able to do on a regular EMR, right? And that's one of the things we and IRC have been really adamant about showing is clinical data expanded out that's relevant and actionable. So right off the bat on the left-hand side at the bottom, you'll see a list of blood pressures pre and post. And this can drag down for weeks, even months. But you can see here, Ms. Peters, her systolic blood pressure is never leaving the 150s, 160s pre or post dialysis. So she's leaving with high blood pressure every single time. Then you can go in and do a deep dive. And Carolina, can you go back a little bit? I think you went ahead a little bit. Yeah, keep on going back. Yeah. Sorry, keep on going back. Right off the bat, you can to go into a deep dive on the patient. You can go into the different metrics that matter on a dialysis patient. So one of those you can go into is anemia, right? And look on this. If you can see here, you can see a hemoglobin trend over the last 6 months. This is not data I get to see very often, Sarah. Like, I don't know if you see that, but typically on our EMRs, we don't get to see data like this outlaid over such a period of time. You can see here that her hemoglobin is typically running in that normal range, 10 to 11.5. She has some outliers here and there, but it's there. Now, what's cool is when you work with us, we'll have Mircera dosing, ESA dosing, Venifer dosing overlaid on the different points in time along this graph. So you'll actually know how your ESA is actually working and if it's working at all. So you can find errors. But in Miss Peters right now, we don't see any problems with anemia. The anemia is not the issue of why she feels weak and tired and why there's a prediction for a fluid overload, right? Next slide. Then you want to look at adequacy. Are we getting good clearances on the lady, right? Are we getting good clearance on the lady? KT over V is looking good. Now you had a little dip there in January, but you did a repeat and the KT over V came back normal. So you know what? Adequacy is not as much of a concern. So that's not a concern. Next slide. Then you can see here, we give you a list of mistreatments that the patients had over that period of time. You can see those dots actually list mistreatments. You'll actually be able to see if that patient would actually reschedule that appointment or missed it completely and what happened. You can see here in January, she did miss appointment there. So is that the reason why, why she's had high risk for fluid overload? She missed an appointment, missed her dialysis session, right? Do we need to do a makeup session for that? Next. And this one I think is so useful is to be the ability to see dry weight over time, right? To see person's weight over time and the adjustments made for it. This is one of the greatest aspects of working with IRC on this is just seeing trends of this over time. And you can see here, the red line there means the established dry weight. You can see that's consistently going across. That blue line, that dark blue line actually represents the weight that the patient is bringing in to dialysis, right? And that light blue or turquoise line actually represents what they were able to achieve by taking off on that dialysis session. And you can see there that that light blue line, that turquoise line, is not meeting up with the dry weight. So this patient is not achieving her dry weight over several months now. And in fact, in that last session, you can see here she brought in 76 kilos, even though her dry weight is actually down there at 70 kilos. And in our last session, she was at 72.5. They only got her down to 72.5, leaving over 2 liters. So is that the reason why she's at risk for fluid overload? Again, giving you that ability to do that deep dive on a patient, and maybe say bringing her in for an extra dialysis session, extending time and doing that dialysis session a little bit longer, decreasing the dry weight, whatever that next best action should be. We give you the ability to actually look at the patient better and make that assessment. Next line. Areas of concern as well too. Go back. You can actually see previous hospitalizations. So over here, you can see that, she actually had 2 hospitalizations in January. And when you work with us, you actually hover your cursor over that dot. You actually can see why they went to the hospital. Was it pneumonia? Was it fluid overload? What was the reason for it? Next line. Next slide, excuse me. Now, one of the biggest questions we get is, I already know what you're going to ask, right? Are these patients, I don't need to know about my non-compliant patients, right? We all know Mr. Gonzalez never shows up for dialysis on Wednesdays. Or Mr. Smith, he misses 3 times a week or whatever it is, or twice a week or whatever it is. By the way, just so you know, this is all synthetic data. This is not actually real data. This is all synthetic. So, but I'm giving you names in our that are just kind of for you to relate to it. So what's cool with us is IRC and the nurses we talk to there, the clinic managers were like, I don't need to know the patients that are not showing up. I already know they're high risk. So we give you this ability to actually see attendance compliance and duration compliance. And you can see here it listed. Not only that, at the top, we have splicers there. So you can actually comb out the non-compliant patients, thereby giving you the compliant patients that are more high yield, that are the people that you can actually make an impact on. So not just delivering you the people that are just the ones you expect, but the people you may not expect. And that's what I love about our dashboard as well. The other thing is this dashboard, what I like about it is it can give you that high level overview of your company as a chief medical officer. It can give you that regional information as the Southwest regional manager, but also give you that information if you're a clinic manager or a dialysis medical director of a local unit, and really hone in on those patients that are high risk for fluid overload. So, but yeah, Sarah, I would love your input on what I said.
Yeah, no, I think it's great. I mean, I think to level set, I started in nursing when we still had the 3-inch binders, and you would have sections divided out that you would have to comb through and handwrite and try to decipher. I love you, doctors, but I got really good at lots of different languages, and it was all English. It was just the way you wrote it. But it really has been an interesting space in which for us to be practicing in healthcare is it has went from one space to this new space, and it's been really exciting to see. In dialysis care and nephrology in general, we have all the information. There is a ton of information out there, but what we really lack sometimes is a way to bring that together in a meaningful way, especially for the people that we expect to take action and to communicate with our physicians. And so through this partnership, there is this, this depth of intelligence happening in the back end. But now in our partnership, we were able to work through how do we make this relatable and less intimidating for people that we're asking to use this system. And it's been really an honor to be able to see people find value and meaning in it. We have an exception-based culture, right? We have the benefit of knowing our patients probably better than most other specialties get to know their patients. And we need to leverage that to be able to help bring those aha moments. And the aha moments could potentially save a life. And so that's a really good aha moment to have with our reporting system here. Going through these different screens, you can get into the weeds as far and as deep as you need to go. But as a chief nursing officer, it was really essential for us to find ways to make this bite-sized and applicable to the existing processes that they have in their centers. And I'm excited to see some of the results and see the excitement and the openness to something that, still feels a little sci-fi to some people that have been in the healthcare world for a while now. And it's been a pleasure, and it's been really rewarding to overlay that with actual improvement in results and improvement in workflows and improvement in efficiencies and operational processes.
Yeah. But I would say, Sarah, it's like what's been cool about working with you guys is like I've learned a lot too, not just from you guys, but like, I always say I never knew what I never knew, right?
Yeah.
Like I didn't know I could have such a good perspective on a patient. And as we went through these boards, I was like, man, I wish I would have had this on when I was doing
Right.
dialysis rounds,
Yeah.
right? Like it was like an overview of a patient. I could actually see this done there, the monthly that visit, that monthly visit that we're supposed to do, like a physician or whoever looking at these labs and looking at over time and getting a really good assessment over somebody. And I feel like we get so in medicine as a whole, but in nephrology even in particular, we get that snapshot of that patient, right? How's she doing on Tuesday? Like we don't get that
True,
perspective
right?
of like the last 2 weeks or 6 months. This is what Miss Gonzalez, Mrs. Smith, whoever has been doing. Really, is her dry whip been trending down, and is she losing weight?
Yeah.
We have some of that, but it's not always like in one location to where we can get that good information.
Yeah.
So
Right.
that's what's been fun about that. So
We talk about AI here at IRC as additional information in AN&I, but also it's awesome insights. The fact is,
you
everybody.
got acronyms for days right now, don't you?
I do. I do. It's a talent. It's a rare talent, but really, I think that, when we're looking at these dashboards and we're talking about it to different people, whether it be physicians or a PCT or whoever that may be, it's how do we point them to the place in which they're going to find value? And I really do think that the dashboards and the way in which you can navigate through them really easily allow whoever to find value in it. It's pointing them, it's helping them understand, oh, if you want this huge comprehensive picture that goes back 6 months because your brain really wants to think about what the next 6 months look like, great. If you are a PCT who wants to know, or a nurse who wants to know right now, what do I need to have and call my physician about to have a conversation or work through a protocol or standing order on, it can be just like that. And so much of the world is becoming more efficient, and we're getting more and more tools and more resources. But with that, we're just adding on more tools and more resources. And so having a tool like this that can pull all of those things together in, like you said, a meaningful way that you can just look and make a decision, or at least influence maybe your decision, is an exceptional reward right now in dialysis care.
Well, like even like for like again, like seeing a hospitalization, like someone's at risk for hospitalization and missing it, right? We've all seen these patients. It's nice to have something out there that's like the AI predicting that, hey, this patient's a risk, and I can look into why. And so, you know, there's so many of these patients that went, well, where is she today? I was like, oh, she went to the hospital. No one knew, right?
Yeah.
But if you
Yeah.
can just give it a little extra TLC to that patient during that week, perhaps you can prevent that hospitalization. Sometimes it's just 2 or 3 kilos that's on them that really
Right.
cause them to go to the hospital, right? So,
Yeah.
but overall, like, how has your staff been, like the clinic managers and everything? I know I've talked to them, but how are they taking it and how are they liking it and everything?
You know, I think that what's been really great to do, and we've just collectively been educating in the organization, is really bringing it down to those different roles and functions in the center. This is a great resource for physicians. There's tons of applications there, but I really wanted to make sure that we as an organization were as prescriptive as possible, you know, to bring those aha moments. And I'm lucky enough to have a brilliant social worker advisory panel and a dietitian advisory panel that keeps us relevant, right? That keeps us having a really good group of people that still manage patients from the front line, giving us their perspectives. And, you know, this last time around on that initial dashboard, you see the different circles that talk about the different metrics where there's opportunities. And we've just broken it down to a granular level. With a social worker, it's, hey, see this little circle right here that tells you how many patients at your center are predicted to miss a treatment. How nice is it to have a proactive conversation in our space? We don't get to do very, very many proactive things sometimes. Often we're reactive. Often we're doing these different things. But here's this way for a social worker to get to go and, like you said, TLC a patient that they care about and love and know that their granddaughter's birthday is happening this weekend and are able to go, hey, I remember, you know, it looks like we might have some opportunities for us to make sure you're going to be able to come to all your treatments. Is there anything coming up that we need to know about or to reschedule? Because it's so important that you get those treatments and have more of a proactive, I care about you conversation instead of a reactive, why didn't you come to treatment type of attitude, right? Our patients deserve us to continue to fight for innovation for them. And our staff and our teams deserve ways in which they feel like they can make a difference every day, because healthcare is hard. And if we don't find ways to let them feel that they're connected and they're making a difference and finding ways to make their roles easier or clearer, then we're not doing our job as innovative anything. So it's been truly an honor to get that feedback from the team. And the reality is, if you put this out across thousands and millions of patients and we make a difference and we prevent something for even one, I'll argue till the end of time that one was worth it. And so it's just been a really great thing to talk about and to motivate, and also, you know, find ways in which it makes the day go a little easier for our teams that are trying to manage so much while also still maintaining a great connection with the people that they care for.
Well, I think with the boards too, like you said, I think bringing other players in the care team on board and looking at the boards is so crucial as well too. Like, say, a dietitian, we didn't show it, but you can actually trend phosphorus, you can trend albumin.
Yeah, right. We can
overlay
talk
that with
about
draw
that.
weight.
Exactly. We can talk, hey, can you have a conversation about your diet and how you're doing managing, you know, your salt and sodium intake? And it's great. Yeah.
Yeah.
I wonder if I could just jump in here and moderate a little bit. You guys are having such a great conversation. I didn't really want to, but one of the things that struck me, Sarah, 2 things actually, when you mentioned metrics and bite size. I love that phrase. Of course, I love all the acronyms that you developed as well. But one of the key aspects of the white paper, and we kind of touched on it a little bit, maybe you guys can expand on, is the white paper covered the decrease in hospitalizations by 27%. Direct impact to decrease in mistreatments. And it seemed like a lot of that was driven by the Renal AI's next best action recommendations. Maybe just a quick minute on just the, you know, it's one of the secret sauces we think of our Renal AI is the AI provided hyper-personalized next best actions. Maybe just a quick conversation from the 2 of you from the different perspectives of where next best actions play a role, because we think that really drove, of course, decreased mistreatments and decreased hospitalizations.
Yeah, I can take a swing first if you want.
Oh, go ahead, sir.
Yeah. I think if you talk to anybody that does dialysis care and you say, hey, what can potentially happen to a patient if they miss it, if they don't have adequate dialysis, they're going to say, oh, they can get hospitalized and things like that, right? Like you have that fundamental knowledge because you're a qualified healthcare professional. But now when I look at a board, it's hard to ignore, here is the data saying that they have issues. Here is the risk that they're going to miss a treatment, and they are this high risk for hospitalization. And we call this kind of our triage board for a reason, that we clinically know all of this, but sometimes you need it pulled together, as you said, in a bite-sized way for you to propel and take action. And it's hard to ignore red. We all chase the red, right? But it's also hard to ignore all those pieces being pulled together and saying, hey, you love your patients, you're good at your job. How do we use this to have great, meaningful conversations with physicians and with our patients, and actually maybe prevent and extend their lives? So that's how I see it, is that there's knowledge and we know this and we can find it, and there's always a fluid management board, and there's always all of these different places that these metrics exist in most EMRs out there. But to collectively pull that in a meaningful way, and then say simple triggers, contact the physician about this, think about doing this, what about this? This isn't telling you how to be a healthcare professional. This is telling you, hey, we see something that if you maybe take this action, the results show that it's going to help your patient. And that's what's been so great about it.
I would say, let's add to that, like, I think data doesn't mean anything without perspective, right? So like no one exists in a point in time. No one's one lab, one blood pressure, one phosphorus, whatever. So again, being able to see that over time. But also the next best action component, remember, we're a clinical decision support tool. So we're not making decisions. This is not to replace the doctor. And you had a bunch of acronyms for AI. I call it augmented intelligence. So it never replaces the physician.
Still fancier than
It's a bigger SAT word, right? So it's augmented intelligence, augments the physician's intelligence to make them have a better decision or better impact on the patient. So that's what I like about it. And again, they can take action, they not take action. That's on them, and it always leaves it on the physician to make that decision. So
yeah. I think it was interesting when we saw the NBAs, as we'll call them, do another little acronym there. But the next best action, that's why I say NBA. A lot of them, when you're dealing with a group of 10 patients, let's say, a lot of them, they're like, well, of course, if they do another treatment, or of course, if we do this, like, there are those statements where your teams know these patients, your doctors know these patients. And so you'll go down a list of 10 people, and what has happened in every single training and every single time we pulled up a list of a facility in front of that team, was they immediately found the name that surprised them, and they immediately go in to disprove it. And my argument, like I said, will always be, what is the harm in taking a closer look at a patient? There's never a downside to that. But the fact of, most often you go in there and you see something and it propels action. And that's all of these tools and everything need to do. It needs to propel action based off of your intelligence, your decision-making, your knowledge of the patient. And I think that's been really interesting, because every single room, it's just, I can almost like bet on it, in Vegas, like, somebody's going to open their computer and dig right into that EMR. And that's a great thing. That means that we're still committed to taking action, that we still want to do good things by our patient, but we're also cautious, and we doubt new things when they come to us in healthcare. And so we want to prove it out, right or wrong. But at the end of the day, proving that somebody isn't going to go to the hospital, there's not a downside to that. There really isn't. So that's been, it's always kind of fun to like time it and 3, that's what's going to happen.
I do hate to interrupt, but I know we have we're past the hour, but so I need to kind of wrap this up. And one of the things that I love is, data does not mean anything without perspective. And one of the things that just is kind of a teaser, maybe a spoiler alert for the white paper, is when you think of some of the accuracy levels of our next best action, they're in the 90+ percentile. So take a look at the white paper. And as far as, Carolina, if you want to go to the next couple of slides, to learn more about IRC, please join in looking at Instagram, Facebook, and LinkedIn. Where you'll see the white paper, there is a QR code. Please scan. And then for Dr. Butt, to learn more about his amazing Your Kidney, Your Health podcast, a little plug for Dr. Butt.
Oh, thank you.
Please join us. Please join him. And then finally, we all know that the next couple of weeks are going to be pretty important for different kind of Kidney Week, ASN. So please join DeLorean for Wednesday celebration, and with IRC for the 24th cocktail reception. The 23rd is with DeLorean, and the 24th with IRC. Please join. The information is in the chat room. And then finally, if you will be attending ASN next week, please join DeLorean AI at booth 1031 and Innovative Renal Care, IRC, in 2303. With that, if I could just ask one question, and this has been as a wrap-up, this will be the final question. As a wrap-up, so often when I talk with organizations, family, friends, etc., about AI, they always have a question about just AI. But so for each of you, if you had to answer the question of how AI will help in healthcare and these types of solutions, what it would be. Now, we've gone through quite a bit, but just in general, how does AI help healthcare teams, and let me rephrase that. How do we make sure that our teams and our staff that we deal with are open to AI? That's a better question. So Dr. Butt, you want to lead us off?
Yeah, sure. So I would say in order for them to be open to it, they have to not fear it, right? I think people have an inherent fear of what AI is and what it does. And so from my perspective, I don't think, like taking that fear out, letting them know what it is, giving some transparency. Again, like we don't make the decision for you. We give you the ability to do that deep dive on that patient and learn about them yourself. So taking that fear out is crucial. It's one of the things they call it is the black box warning of AI, right? How does it get to where it's getting, right? The other component is like really like, especially over the last few years working with DeLorean, again, what I never knew what I didn't know. So not having all that information and getting that long-term perspective on the patient, I was like, oh my God, like I missed out on a lot. So I think one of the things that AI enables you to do is collect data and put it, giving you a better perspective on that patient. And I think that's something that's invaluable that we don't get in healthcare. So.
Yeah, I think that's a great answer. I'm really excited and inspired by when we bring things to healthcare that we've involved healthcare. I think it's really, really important for us to think about the end user, who we really hope this is going to help, and be open to their feedback and be open to pivoting and trying to solve problems that they have in their day-to-day workflow. They may not even know the problems that they have in their day-to-day workflow until you use that collective innovative thought process. Say, hey, we can maybe solve for this, but we need your help with this. I think the way to make AI and anything less scary is by having conversations and seeing what needs there are out there and things that we wish we had or wish we could do better, and be open to help design that. And healthcare needs to be a part of designing the future of where we're heading, whether it be AI or anything. And I think that if we continue to do that in a collaborative way, we're going to have a result that's just awesome. I mean, that we have where we actually get to spend more time with our patient than in front of our screens, that we have tools that are actually usable to have conversations, not just printouts. It's definitely, to me, a good landscape that we're heading towards. And it's a needed landscape because we're asking people to do more because we have more information. And we actually, in healthcare, I went into it because I really do love to have a good conversation and change somebody's lives where I can. And I'd love to have tools that help me do that better. So I hope that's responsive.
Very good. With that, it's a wrap. Sarah and Kazim, thank you so much for your time. The audience, as always, we appreciate your interest.
Thank you
so much.
You guys have a good day.
Have a great day.